हेलो फ्रेंड्स, कैसे हैं आप? होप यू आर डूइंग वेल. सो होप you have subscribed this channel to get new video and press the bell icon to get information regarding new videos I am uploading again and again. So today's topic is the pancreatic carcinoma or pancreatic neoplasm. Thank you, Dr. Nirupama Gupta ma'am, for her contribution in MCQ parts. So let's start. Neoplasm of the pancreas. So what are the tumor included in periampullary neoplasm? So this is the area which is situated here. That is the where the duodenum and common bile duct are meeting and pancreatic duct are also draining. So this is the area known as ampullary part. So the periampullary carcinoma are a descriptive term where different carcinomas are included in this term. So it may be the ductal pancreatic adenocarcinoma, it may be ampullary carcinoma, carcinoma of duodenum, and distal cholangiocarcinoma. These are the terms or cancers included in these periampullary neoplasm. So pancreatic ductal adenocarcinoma, ampullary carcinoma, duodenal carcinoma, and distal cholangiocarcinoma. Most common symptom of periampullary carcinoma is the jaundice, obstructive jaundice, because of the obstruction of the common bile duct, which is common to all these cancers. So pancreatic neoplasm, the most common primary pancreatic neoplasm is the pancreatic ductal adenocarcinoma. Though the metastasis to the pancreas is much more common as compared to the primary pancreatic neoplasm. The important findings or important points regarding the pancreatic neoplasm is that it's a most deadliest carcinoma, that is pancreatic ductal adenocarcinoma, and 5 years survival rate is only 2 to 5%. Even surgery rarely cure it. Most common site of the pancreatic carcinoma is the head of the pancreas. About 60 to 70% neoplasm are situated here. Hallmark of the pancreatic carcinoma is the double duct sign, that is the dilatation of the common bile duct and pancreatic duct. Best diagnostic modality for the diagnosing pancreatic carcinoma is the multi-detector CT or MDCT. Now, what are the risk factors for the carcinoma pancreas? Smoking is the most common risk factor for the carcinoma pancreas. Obesity, chronic pancreatitis, diabetes, cirrhosis, smokeless tobacco, family history of the pancreatic carcinoma, and Peutz-Jeghers syndrome. These are the risk factors for the carcinoma of the pancreas. Some important points regarding the pancreatic carcinoma is how can we detect the pancreatic cancer. So sonography and CT are the primary tool to detect the pancreatic cancer, especially the pancreatic carcinoma in periampullary neoplasm. Then sonography often detect the pancreatic carcinoma because it's a method of choice to screen the patient with jaundice and pain. So you have opportunity to detect it. USG sensitivity is 72% to 98% in the experienced hands. Multi-detector computed tomography is the most sensitive, about 97% is there because it's not operator dependent. CT is less operative dependent. And MRI, MRCP, ERCP, and endoscopic ultrasound have comparative sensitive to the CT, but reserved for the problem solving or special circumstances. What are the clinical presentation of the carcinoma of the pancreas? So usually it's asymptomatic until late in course. So and clinical presentation depend on the site of the primary tumor. So obstructive jaundice is the most important clinical features. Body and tail having the weight loss and likely metastasis to the liver. Most commonly present with the distal metastasis, least likely present with the tumor confined to the pancreas. Then serum biomarker may be used in the carcinoma pancreas in a difficult case. The CA19-9 is the biochemical marker used in the CA pancreas. Some important demographic findings are the age. It is 60 to 80 year is the common age of presentation of the pancreatic carcinoma and peak in the seventh decade. Male female ratio is 2:1, that is male having more predominance or prevalence of the pancreatic carcinoma. And it may be that the male usually smoke more, so they have more chances to get the pancreatic carcinoma. It is the second most common GI malignancy after the colorectal cancer. Then ULG features of the pancreatic carcinoma is most important is the double duct sign where CBT and pancreatic duct are dilated, may or may not be deformed shape of the gland, hemorrhagic or hypoechoic mass calcification may be there. Then small intratumoral cystic areas may be there. Then there is posterior obstructive pseudocyst may be present, or glandular atrophy is maybe the presentation of the pancreatic carcinoma. But most important is the double duct sign. Next important thing we should aware that there are a criteria which suggest the unresectability of the pancreatic carcinoma. So these points you have to remember that tumor larger than 2 centimeter, if there is vascular invasion, evidence of vascular evidence is there, extracapsular extension is there, lymphadenopathy or metastatic disease are there. So if these criteria are there, then that pancreatic carcinoma is not resectable. There, the pancreatic color Doppler score is used to assess the resectability of the pancreatic carcinoma, in which the scoring can be done whether it's involved that particular vessel or not. So grade score 0 is that when the tumor does not touch as a vessel or not involve it. Grade 1 is the then tumor touches the 1 to 24% of the around the blood vessel circumferences. Then if it is score 2, then the tumor touches 25% to 49% around the vessel circumference. Then grade 3 or score 3 is the when the tumor touches 50 to 99% around the vessel circumference. Then grade 4 or score 4 is the when the tumor encased 100% around the vessel circumference. And grade 5 or score 5 is the vessel invaded or occluded. So these are the score for the pancreatic color Doppler score where we can see the resectability. So you can remember 0 no touch, 1 25 for up to 25% touching around the vessel circumference. 2 is score 2 is 25 to 49%, score 3 50 to 99%, score 4 100% encasement, and score 5 when is vessel is invaded or occluded. This is the few ultrasound picture which are showing the pancreatic carcinoma. So there is a diffuse involvement of the pancreas. Only 5% of the all ductal adenocarcinoma are diffuse, and this is the rarest of them. So this is the rare tumor, the diffuse involvement. This is the double duct sign. Only common bile duct sign is depicted here, which is dilated, and there is a hypoechoic mass is there, which is obstructing this common bile duct. This is the pancreatic carcinoma. Then this is the again a mass is there, which is causing the uh, obstruction of the pancreatic duct. Then this is the pancreatic ductal adenocarcinoma, which causing the pseudocyst. There is in the body there is a subtle cancer in the body of the pancreas. These are the cancer, and pseudocyst peripheral to mass is there. This is the obstructive pseudocyst secondary to the tumor of the pancreas. There is a, this is the pancreatic carcinoma, which is this hypoechoic mass is the pancreatic carcinoma, and which is encasing the celiac axis. Now, treatment of all these periampullary carcinoma are the Whipple procedure or the pancreaticoduodenectomy. As the name suggests, pancreas and duodenum are removed in this procedure. This is the before the Whipple's procedure, where the gallbladder is present here, bile duct are present here, pancreas and its with cancer is present here. This is the duodenum. So all these um, structure which are purple colored are removed in this procedure. So what we do in the Whipple procedure? In Whipple procedure, the head of the pancreas and the tumor involving the pancreas is removed. The duodenum is removed. The gallbladder is removed. And what we done is first we join the pancreas, remaining part of the pancreas to the remaining part of the small intestine. So here the pancreas is joined to the small intestine. Then we fix the bile duct, common bile duct to the small intestine. So we are attaching this common bile duct to the small intestine. And next is we attach the stomach to the small intestine. So what is happening is the pancreas secretion are they coming here. Biles and liver secretions are coming from here, and then it going forward, and the stomach partially digested food particle will drain into the small intestine, where they mix up with the pancreatic secretion from here and the bile secretion from here, like this. Now we will review some MCQs so that we can check our knowledge. Most common site of the pancreatic carcinoma is head, body, or tail. So answer is head. 60 to 70% are pancreatic carcinoma are in the head of the pancreas. Most dangerous carcinoma is the pancreatic ductal carcinoma. Is it true or false? So it is a true. It is the deadliest cancer. Most common is the pancreatic ductal adenocarcinoma, which is mostly deadly. True or false? Yes. In periampullary carcinoma, pancreatic ductal adenocarcinoma is the most common one and deadly also. Most common symptom of the periampullary carcinoma is pain, jaundice, or fever. So we already discussed it's obstructive jaundice, which is the most common symptom of the periampullary carcinoma and group. Pancreatic carcinoma is the more common in male or female. So we already discussed that it's a more common in the male with 2:1 ratio. You can remember that male smokes more, so they get this pancreatic carcinoma more. Best diagnostic tool for the carcinoma pancreas is USG, MRI or MDCT or multi-detector computed tomography. So answer is MDCT is the best diagnostic test for the CA pancreas. Metastasis to the pancreas is from all of the following except renal cell carcinoma, malignant melanoma, breast carcinoma, lung carcinoma, and colon carcinoma. So answer is malignant melanoma does not metastasis to the pancreas. Next is what is the common USG appearance of the pancreatic adenocarcinoma? So answer is it's a hypoechoic mass, which is the most common appearance of the pancreatic adenocarcinoma. Mucinous cyst adenocarcinoma of the pancreas is most often located within which part of the pancreas. So it is situated mostly in the body and tail of the pancreas. Body and tail is the correct answer in this. The Whipple procedure is performed in the patient who have chronic pancreatitis, acute pancreatitis, pancreatic carcinoma, or pancreatic transplant. So answer is pancreatic carcinoma. Hallmark of the pancreatic carcinoma is sliding sign, seashore sign, bagel sign, or double duct sign. So answer is double duct sign is the hallmark for the pancreatic carcinoma. Whipple procedure is also called pancreaticoduodenectomy. Is it true or false? Yes, it is true. Risk factor for the pancreatic ductal adenocarcinoma are cigarette smoking, chronic pancreatitis, diet rich in animal fat and protein, obesity, diabetes mellitus, all. So answer is all are the risk factor for the pancreatic ductal carcinoma. Pancreatic calcification is frequently seen in carcinoma pancreas. Is it true or false? So it is false. Pancreatic calcification is more common in the chronic pancreatitis. Relationship of the tumor to surrounding vessels, that is supine mesenteric artery and celiac axis, predicts resectability of the tumor. If the carcinoma surround a vessel by more than 180 degree, then it is unresectable. This is true or false? So yes, it is true. An important sign to differentiate between chronic focal pancreatitis and pancreatic malignancy is block sign, bagel sign, slide sign, or duct penetrating sign. So answer is duct penetrating sign. Duct penetrating sign is a radiographic sign that can be useful to differentiate between the focal pancreatitis or inflammatory pancreatic mass from the pancreatic carcinoma. What is the duct penetrating sign? It's a positive sign when a mass is penetrated by the unobstructed pancreatic duct. This makes the focal pancreatitis the most likely cause rather than the pancreatic carcinoma. So it is the pancreatic duct is not obstructed and penetrate the mass, then its chances of focal pancreatitis is more likely. Heavy alcohol consumption alone is strongly associated with the carcinoma pancreas. Is it true or false? So it is a false. Alcohol is not related to the carcinoma pancreas. Coarvoisier gallbladder, that is painless jaundice and enlarged gallbladder, is clinically present in the patient with the carcinoma pancreas. This is true or false? Yes, it is true. It is the painless palpation of the gallbladder seen in the carcinoma pancreas. Lipase hypersecretion syndrome present in 10 to 15% cases of the carcinoma pancreas include all except polyarthalgia, subcutaneous fat necrosis, elevated serum lipase, eosinophilia, elevated serum amylase. So, answer is elevated serum amylase. So, lipase hypersecretion syndrome is not associated with the elevated serum amylase. It is associated with the polyarthralgia, subcutaneous fat necrosis, elevated serum lipase, and eosinophilia. Serum marker for the carcinoma pancreas is CA 19-9, CA 125, CEA, both A and B, and both A and C. So answer is both A and C, that is CA 19-9 and the CEA, carcinoembryonic antigen. Then pancreatic adenocarcinoma involving head and uncinate process in 2/3 of the case and body and tail in 1/3 of the case. Is this true or false? Yes, it is true. So thank you all of you for your kind attention, and hope if this video is useful for you and a sonologist undergoing CBT examination. Thank you all of you.